and welcome to this training session. Very pleased to have participants from 15 different states within India and also from 3 countries in total, Bangladesh and Ghana. Welcome, and we're delighted to have you with us. We are now in week 9 of this program, and my name is Smriti. I'm the program director at Pallium India, and watching this program evolve into what it is now has been an absolute pleasure. I'd like to thank everybody at the PalliCovid team who has put in all this effort, and the original ebook in the resource toolkit was put in with painstaking work done by them. And we're happy to partner with them and help develop the webinars and now have this program. Our original team has over the last few weeks been immeasurably strengthened by the entry of new faculty members who are here with us today. And I'm going to just quickly introduce you to our lead facilitator and our co-facilitator for today. Our lead facilitator today is Dr. Mhoira Leng, who has had incredible amounts of experience all around the world as a palliative care physician in different settings, including in humanitarian crisis settings in Gaza and in South Sudan, and so comes to us with a lot of expertise and humanity. And she's also been associated with the Indian palliative care scenario for about 20 years now, currently with the University of Edinburgh and the medical director of CARDIS. Our co-facilitator for today is Dr. Dinesh Kumar, who is a professor of community medicine at the Pramukh Swami Medical College in Anand in Gujarat, and also long been in the palliative care field, comes with a lot of experience. In the audience, we also have some of our other faculty members who will be pitching in from time to time whenever required. So our topic for today is triage in COVID-19 with special issues in reference to management of ethical issues, basically decision-making, goals of care. And I'm now going to hand over to Mhoira. Mhoira, thank you very much for being with us today.
Lovely, thank you so much, Smriti. It's such a pleasure to welcome you all and to see the diversity. I think North India is really well represented today, so thank you for that. As I start, we've got a couple of issues to do at the beginning, and then we'll get on to this topic. Dr. Dinesh will be helping me. But I really want to encourage you to use the chat. So as we start, can I ask you to start putting in the chat your name and where you're from, and if you haven't done that, but also putting in what are you wanting most from this course? Why have you joined this course? What is the reason you're here? Just put it in the chat, and we can just get a feel, get to know one another. And as we go through these sessions, particularly through this week, we're going to be inviting you to share experiences, learn from one another, and make this as interactive as we can, despite being obviously on a Zoom call. I want to just say welcome, particularly for my colleagues from Mizoram that I've had the pleasure of visiting, and I hope you're seeing I'm just wearing something to tribute to Mizoram this morning. Okay, let me just introduce. So a few slides of introduction as we start, and as I'm doing this, please put on your expectations, because as we finish a few slides, we're going to look and see, and my colleague Dr. Dinesh is going to be keeping an eye on what you're saying so that we can share together. So as Smriti said, this is an online course that complements e-learning materials that hopefully you've already had and you've had a chance to look at, but if you haven't, I'm going to signpost for you so you can get the most out of this week, because this is a week in which we do sessions based on you having had a chance to look at the materials, watch some of the standard webinars, which are more comprehensive, in order to then get the most out of the interactive sessions this week. We want to empower you as healthcare workers to support those who are infected by COVID, but also populations affected by COVID, particularly thinking of our patients with chronic disease and comorbidities, as well as look at how to support one another as we bring our humanity and compassion into this pandemic response. There's a number of competencies we'll cover, but they really concentrate on these domains. You should have this in your pre-course material. If not, you will find it definitely when you look through your ebook. So we're going to be focusing on issues of triage today, then looking at symptom control, including communication skills come into all of these things. Then very importantly, the management of distress, end of life care, and care for the healthcare worker. We're not going to do it in that order, but these are the topics we're covering. And we're really happy to take questions, find out what things are important to you, and try and weave those into the week in whatever way we can. You have the ebook, you have, which please, if you haven't downloaded, download now. That contains things like algorithms for management. It's much easier if you've had a chance to look at those and think, how would I apply that in my setting? We also have, of course, these 5 sessions this week, and we're looking forward to that. And we give you the background webinars, as I mentioned already. And that together makes the toolkit training resource. We're going to do a lot of signposting. So there may be information and knowledge that you would like. Hopefully we will signpost it to you or be able to answer questions. And this is an English speaking week. We also hope you can use these resources to take forward teaching in your own settings. Some people, Bangladesh, are here. I gather the toolkit has already been translated into Bangla, which is very good news, and we're looking forward to that extending. Ghana, it's lovely to welcome you if you're on, and I know I've met several of you when you've come for training in Uganda. Okay, so what is palliative care? What are we meaning by palliative care? This is a very new definition, and it's talking about holistic care for people with serious health-related suffering. That means people who have chronic illness or acute on chronic illness, such as we see in COVID-19, who are experiencing severe suffering. It's particularly relevant at the end of life, but actually is relevant from a point of diagnosis of someone who has a serious illness, chronic illness, and it focuses on families as well as their caregivers. Palliative care in humanitarian settings is a very interesting area. Quite a few of us have been working more on that. In India, focus has been on situations such as the floods in Assam and Kerala, Nipah virus. Of course, you see here a picture from Nepal and the earthquake, and from work we've been involved with in South Sudanese refugees in Uganda, just for an example. So we have a WHO guideline. We've been looking at what are the key things we need to make sure are there, and along comes COVID-19. And it's being described as a tsunami of suffering. One of the other questions we may ask you in due course is, what is suffering in your language? I think we've got many, we're in English today, many of you speak many other languages. In your heart language, what is suffering? What does that word mean in your heart language? And this paper in the Lancet, produced by lovely colleagues of ours, is backing up what we're covering in this course. Communication and goals of care, symptom control, particularly for those for whom disease escalation is not okay, psychosocial spiritual care, end-of-life care, staff support. And the WHO have now released an excellent guideline at the World Health Assembly, reminding us that we must include palliative care. This is very helpful. If you're involved in advocacy at your government level, these documents are very helpful. And they've identified the vulnerable populations who are really our populations that we see as healthcare workers at every level, those who are older, those who are particularly at risk, comorbidities, and so on. We'll talk more about that. And these are some of them. Refugee children, Rohingya, prisoners, a big issue. Migrant workers returning to Nepal. South Sudan refugees managing some social distancing. And of course, our elders, our older population. This is particularly a disease of our older population. And we're seeing amazing acts of kindness all over the globe. And that's incredibly reassuring to see these humanitarian responses, which are coming from people's hearts. And that underlines the basis of why we're talking about palliative care and COVID today. It's about our common mortality and humanity. It's about compassionate, dignified response to ease suffering, while remembering that we are all human beings caught up in these events and sharing in these sufferings together. So Dr. Dinesh, how are we doing with our chat? Can you help me just understand whether we have anything here on the chat?
No, we don't have any response.
Not yet.
So we are expecting your expectations. And unless we get those, it will be very difficult for us to make it very productive kind of session.
There is one, sorry, from Sonali.
Yeah, just one.
Yes.
Great,
So,
learning tangible skills. Great. I know this is unusual for you to chat, so we're not giving you a row or anything. We're just saying, join with us, get this chat going. So you've introduced yourself, that's great. And I can see all the different colleagues from different places, and you're so welcome from Gujarat, from Kerala, from the Bangla Good. The Bangla translation, Professor Nizamuddin has been in charge of that, so it's great to know. So just keep us saying, why did you join today? What was it about this course that made you wanted to be part of it? And what are the things that are really important to you as we go through this week? We're now going to move into talking about triage. So as you're telling us why you've joined this course, Dr. Dinesh, do you want to get us starting to think about triage?
yeah. So I assume because there's a big number of doctors and nurses in the group, so we assume you might have already have some experience of triage. Is it so? Some of you can mention in the chat.
The other thing you can do if he asks you a question like that, you can just, where are we now? You can just put a tick like this. Yeah, it's not coming up. Yeah, like that. So if Dinesh asks you a question, you want to just answer, you can put a tick like that if he asks you a yes or no answer. So he said to you, are you, is triage something? Triage meaning, are you having to make decisions about who gets which treatment? If you are, then just put a tick. I put a thumbs up in your screen like that. You go to the bottom corner, you go to the right-hand side, and then you can click it. Dinesh, we're getting some nice answers here. Thank you, Dr. Sarika. Excellent. So I think I'm hearing here that there's some issues to do with communication. Absolutely. Issues to do with how palliative care fits into the pandemic, very importantly. Great.
Then how to help the healthcare workers.
Great. And many of you are involved in triage. Are there particular challenges you're finding when you're having to make decisions? Any challenges you're finding at the moment in making decisions?
Okay, so we have a response. Dr. Tasneem, she mentions that she's working in a humanitarian setting and it is a well-established practice in the camps. Okay, and as expected, it is not well integrated with palliative care. So the given situation, we do expect that to happen sometimes.
Lovely. So I think that you've brought up an important point that sometimes palliative care and humanitarian responses are a bit separate. And we have some work to do to bringing those together. We have been doing some work. Perhaps that's going to be an opportunity that comes from this outbreak, is to find ways of working more closely together. I agree with you. Those are very important issues. Okay, Dr. Nash, is it fine if we... Please, please.
I should have mentioned that age is the only criteria for triaging COVID.
I see that. Okay, thank you. Thank you, that's helpful.
That brings us to another issue. How is triage different from what we have been routinely accustomed to? So is triage in COVID setting different from the routine concept of triage that we are aware about? Or is it the same thing?
So thank you, Dr. Dinesh. So you're asking us what is triage, we're discussing, and then obviously what is different in this particular scenario. I see my colleague from ICU is saying how isolating it's felt to make these decisions. Thank you for sharing that. And that's very true. Particularly, I think it's isolating as well because we're all separated off because of infection control. Lovely. Thank you for that. Please keep those discussions coming. Look at your chat because Dr. Dinesh is going to be encouraging some discussion. We'll move on to looking at some slides together, looking at triage, and we're going to incorporate a clinical scenario. And when that comes up again, we'll be asking you to be involved in how we manage. So today's session is focused more on triage, but thank you for the comments you've made because we're going to be able to use those today and also to help inform our teaching this week. Okay, so we have a webinar if you want to look at more of the ethical theory behind this, but we're going to specifically look at the balancing those ethical decision-making issues in a real clinical scenario and also help you look at goals of care and triage algorithm, which we hope will be useful in practice. as well as touching on our own values. Just a reminder, don't forget to find these in your ebook. So if I was to say to you, what are the core principles of ethical practice? I suspect many of you would remember that and your exams from medical school days. And we will review those in a moment. If you remember them, put them in the chat.
Yeah.
But those are principles that help us make decisions, that prevent us from finding ourselves in the middle of a situation and making decisions right there and then, which tend to lead us to make what we call situational ethical decisions. So we just wanted to take a step back and see what are the principles that are particularly relevant in this COVID-19 pandemic times, but are relevant throughout caring for people with severe illness. And how do we then use those principles to balance our decision makings? They will have cultural and context implications, but they shouldn't be changed by culture and context. They're principles, but they will apply in a setting. Many of us are working in low and middle income settings where in fact managing scarce resources is a day-to-day challenge. Our legal frameworks hopefully back up those ethical principles. Sometimes they don't. In India, there has been recent changes that is moving towards them matching more effectively. But it's the applications of these. It's looking at, did you write in there any of the principles? It's looking about how we can, thank you so much, Sonali, you were right on the ball. How we can respect the wishes, find out first, and then respect the wishes of that person and their family context. How we can also make sure that we are not offering and suggesting interventions that are going to do harm, but rather are going to do benefit, and that's important. If something is unlikely to benefit, we have no ethical responsibility, and we should be very careful about suggesting interventions that will do harm, not good. Financial harm as well as physical harm. And we also do that balancing the resources that we have available. That is the justice element. And sometimes that can feel a little bit like a very delicate balancing act. And we might even find this very difficult. So Sonali, you've said you're finding it isolating to make these decisions. So how do we take a step back and think through what to do? How do we avoid feeling like it's a maze that we get lost in, rather than actually some principles and steps that we can go, particularly doing this in advance, so that when faced by a very sick and deteriorating patient, we've thought through some of the issues. Because in COVID-19, we've got vulnerable patients and families. There's a bit of desperation. We've heard of patients being moved here and there, trying to get help. Resource allocation is unequal. Very importantly, holistic issues are being ignored. And much of this week we'll be focusing on issues of suffering and distress and communication. There's a lot of stigma. We're using words like suspects, and the medical staff themselves are the victims of stigma and under extreme pressure. So excellent, thank you for all of those comments. So let's move into looking at a patient scenario. So we're going to meet Ramesh and his family this week, and we're going to use it as an example. Bring in your own examples too, an example of a typical scenario where these decisions come up. So this is an elderly gentleman. He's 75 years old, and he has a number of comorbidities. Usually you just see these written down, don't you? A number of comorbidities. And he also had a significant stroke 6 months ago, and is significantly disabled, having ongoing chronic problems, and is needing help with even the most daily of household tasks. His wife, daughters and son-in-law are there at home. In fact, one son has just come back from the Gulf with his children, and the other son runs a shop. So you can just begin to think of some of the challenges for this family. So far in what I've told you, what are the issues, and Dinesh, you can help me here, what are the issues that would help decide the way forward for this scenario? So this is the scenario I'm giving you. What are the issues coming up here that you're noticing that might help us when we look at the way forward? Any suggestions?
And now suppose if this is the patient in your outpatient clinic or maybe in your home care setting or your hospital. So what are probably issues you'll consider before you come to a decision? I assume many of us would have come across several patients where we found it very difficult to come to a, okay. So Sonali, she would like to consider the patient, Ramesh's wishes. True. What else? Okay, so what does quality of life mean to Ramesh? Again, we have Ramesh's expectations. Good. Then there is a response by Dr. Tasnim, physical, mental, social, and spiritual. So, doctor, can you clarify on that? Dr. Tasnim.
Yeah, I think that's great. If you can give us, people can give us an example of those things. What are the physical, mental, social, and spiritual issues? Thank you. So Dr. Dinesh, I think this is very helpful. We're looking at autonomy, but autonomy is also affected by everybody's opinions, for sure.
Then there is issue of social distancing also, which is norm and it can affect the mental health. Good. There are financial issues that will come up. Then physical, okay. Dr. Tasnim wants to draw our attention to various comorbidities that are there. Okay. There are a whole lot of physical issues that have been mentioned. Being bedbound, being dependent.
Lovely.
Then affordability issues. So we've got a whole lot of issues which have been picked up by the participants.
Lovely. That's really helpful. Thank you. And thank you, Dr. Dinesh. So let's look at these a bit more. So we're wanting I'm really pleased that we're beginning to think of, let's understand the context. So this is not just going to be about COVID-19. This is about a patient, a person living with his family with significant challenges, which maybe some of them have been exacerbated by the isolation and by the issues of maybe access to medications. Is he getting the right treatment? Has he been able to continue with that? Is there a lot of anxiety? Is there mental health worries? Thank you. People with stroke disease are very prone to depression and mental health anxieties. And what are the expectations of him and his family? And what was he like prior? We know that he is able to only do minimal things. Not nearly everything has been done by his family. So thank you for that. So we're beginning to realize that actually the situation in advance of COVID for these kinds of scenarios is very, very important. Not just focusing on one thing, and that is COVID-19. Okay, let me just look a bit further. Thank you. Keep those questions coming. So let's look at some of what we know, for example, about expectation. Now, I think this article has been superseded by another article, so I'll just go on to this one. Thank you. What we know is that those who are elderly, who have comorbidities, are not doing well if they require disease escalation and mechanical ventilation. Now, there are many other interventions that can be helpful. So we're not saying you don't treat the elderly, but here's an interesting question. If you are elderly with multiple comorbidities like Ramesh, is mechanical ventilation a good option if your condition deteriorates? I would just like you to just put some suggestions in there. And I'll tell you, it's been very difficult. I saw papers coming out of Italy where they were overwhelmed with numbers. Their beds were full, and they began to say maybe we should have a cutoff. And I think I saw in the chat earlier that some of you felt maybe there should be a cutoff for the elderly, and the elderly would not be recommended for ventilation. So it'd be very nice to know. Thank you. So one of you is saying so far you don't think escalating and ventilation would be a good option. Thank you. And you're looking at meaningful chance of recovery. Excellent. So we're putting together the pre-existing, what we know about this patient, the medical evidence, and this will change, of course, as evidence comes out and treatment changes. Even now, dexamethasone has been shown to have some benefit, but only for those really very, very severely affected. Great. So we look at the medical evidence. We look at the setting beforehand. We look at the ethical principles. There's some excellent briefing notes being prepared by the major global palliative care organizations. And I really think this first one is important. These are ethical principles. We've covered some of them. Non-abandonment. This person's neighbor is saying to him, you're not going to get help if you need it. Our elderly are feeling very worried. So there's a big difference between saying we're not going to help you, we're not going to care for you, and we don't recommend mechanical ventilation. And we have to be careful how we do that and not make that decision only on our ICU colleagues, but start having these conversations early and make those ethical decisions based on the person in front of us. Now, you may have a good strategy available in your setting. These are strategies from the state of Kerala, which used a lot of the experience they had with Nipah virus, with integrated palliative care, with the floods, to have a very good public response to this pandemic. But you will have something in your setting, so make sure you know what is there, what are the triage system triage issues. But we want particularly to think of how we help a patient and family find their way through this system, and very importantly, to make sure they feel as though we are treating them as valuable, as important, and that we're going to try and together make the best decision. I think this is a tricky algorithm. It's easier to read in the book, but this is trying to say we should start having goals of care discussions early. When this gentleman, Ramesh, if we were in contact with him, we would start to say, how are things going? Are you finding it difficult during this COVID time? Are there things that are particularly worrying you or concerning you? And starting, you will talk more about this tomorrow in the communication session, but starting to frame these questions so that we are having these conversations early, so it doesn't come as a surprise if he becomes unwell and we don't recommend ventilation. And in particular, we don't give the impression that we don't care about him. So whatever we're doing, the communication, documentation, remembering, as some of you've already said, it would not help him to escalate to ventilation. Some of you are saying it depends on his goals. It's very interesting, isn't it? We have to balance all those things together, but also we have to be realistic about what we know of the medical evidence and the results from ventilation. This gentleman, let me just look. So this, I want you to find this algorithm. And I'm going to ask Dinesh to help us with this in a minute. So this is an algorithm which takes you through green, yellow, and red. The green is people with straightforward situation. You feel they're going to benefit from escalation, and you carry on with your usual plan in place, whatever is there in place in your setting. The yellow are those where there may be a challenge, particularly with comorbidities and pre-COVID performance status. Now, I don't know how many of you are familiar with WHO performance status. If you are, can you tell me what number you think this patient has, Ramesh? If you follow this yellow one round, it's taking you to see even people with comorbidities, you may assess them as potentially going to benefit from escalating treatment, which can be non-invasive or invasive. And then they would follow the yellow lines. But if you are assessing them as unlikely to benefit, you are then having that discussion with family. You are documenting this, you are ensuring there is good psychosocial support so that people don't feel that they are somehow being abandoned. And you are bringing in excellent symptom control and discussion about place of care and appropriateness of care. So you can see how this takes you through, with the black boxes being the holistic care, the red, the disease, the flow chart, and you can see the yellow and the red. Any chats about how you're doing this at the moment, or any issues about triage? Dinesh, maybe you can summarize what people have been saying in the chat till now. Yeah, great. So Nali used WHA 3 and 4. I totally agree. Excellent. I love this chat, Dinesh. There's some interesting things being said about goals of care, objectives. So Nali, I think you're making these decisions every day by the sound of things. Okay. Excellent. And you're some excellent chats about outcome. Okay. Do you think this kind of flowchart would help you in your management? Or do you have something similar already? It'd be nice to know how you're making these decisions already. So what we're recommending on this is, if you have a WHO performance status that shows very poor pre-COVID functionality, if you have multiple comorbidities, if you have deteriorating symptoms, we should quickly be assessing how we would move to either referring for ICU management or having those conversations about how ICU management may in fact cause more harm than good. You've mentioned the financial harm for sure. And we should instead be discussing excellent care options which don't involve an ICU referral, and beginning to open up some of the discussions about end-of-life care. Thank you for that. Let me carry on. We're going to have plenty of time for discussion at the end, so please do be ready for that, or a few minutes time, not plenty. So this is the scale. You already used it. We use this one because it's simple. There are other more complicated tools around which are being used particularly in ICU settings, but this just helps us understand what the function of someone was before. The UK are using a scale called the Clinical Frailty Scale. Some ICUs use organ scales, but we're recommending you stick with this more simple scale, sorry. So if we look at this, you've already told me this, he has 4 comorbidities. He was scoring 3 to 4, so he was very significantly impaired. So here we have a few more details about this setting. We find out, and we're going to continue with these on as we go through the week. The anxiety, the stigma, the worry that's going to happen. We're just going to move on from this just now. Oh, sorry. So just a few principles, and then we'll come back to having some discussion before we finish today. We need to effectively communicate in this setting. You have a session tomorrow. We need to be present. We need to say that you're important. We need to say we're going to help find the best for your relative, so that the family don't think, this one is being rejected because they're too old. This one because they don't have money. This one because somehow there's no political connection. You know what I mean? We need to be quite transparent, quite open, use these tools such as this triage tool and document at each stage, showing empathy, showing compassion, not abandoning people. This Zimbabwean young man was the first person to die in Zimbabwe, and he described being alone and scared in ICU. So think about how we can do this even in the situation of PPE and so on. Maybe you can even add that. How can we show empathy in these situations? Because what we're trying to do is preserve that continuum of care. So not thinking they only arrive to us when they have a COVID diagnosis. What was happening before? How can we support people before? If you're in family medicine, for example, primary care, how can we support people in the community to start having these conversations to make sure that their holistic care needs are being addressed as far as we're able, and to make sure that we're helping them make decisions going forward. And also making sure that we have backup and support so that, as Sonali says, we don't feel too isolated in our settings. Now, before we just have our last couple of slides, I want to just come back to you and see what else is in our group. Great. We have last couple of slides to finish in a moment, but any other points you want to raise, any issues that is brought up for you today? Maybe I can ask you just to put a little tick beside your name. Are you comfortable having these conversations with your patients at the moment? If you are, you can give me a thumbs up tick if you're comfortable having these conversations with your patients at the moment. So I can see that some are. Excellent. And we hope that by the end of the week, we'll have empowered and supported one another to have more of these conversations. Thank you. Not always. Thank you, Dr. Shilpa. These are difficult conversations, aren't they? And I think they're particularly challenging when we have, well, tell me, what do you find particularly challenging about them? What is particularly challenging about these goals of care and triage conversations? It's difficult. Can you tell me why it's difficult? Why do you find it particularly difficult? I agree it's difficult. Can you tell me why it's difficult? Sure. So there's Dinesh, feel free to come in, but there's the issues of the physical distancing, expectations from patients and maybe from families also. And that's why it's very important we try and get the patient and the family to realize we're with them. We're with them. We're not fighting them. We're with them. But also there's some medical evidence that's going to help us make the best decisions for their patients. Yeah. So I think in the settings that we're all working with, relatives have a big role, don't they, in making these decisions. Thank you, Abhijit. Absolutely. Now, this is interesting. All across Europe, this has been discussed because the pandemic rolled out fast, didn't it? Sweden is very controversial because Sweden kind of made a decision not to move people from care homes. It was, I think, not made because they didn't like their elderly. They're a country that loves their elderly people, but they made this decision. Even in the UK, they sent people to care homes, and then the disease moved very fast. our care of the elderly colleagues are saying to us, this is a disease of the elderly. Please don't neglect them. Please don't leave people without adequate input. So I think the Scandinavian, it's just Sweden, has said that they did the wrong thing, that they should have been much more active management. That doesn't mean ventilation, but it means active management of associated conditions, of making sure people felt supported, of giving palliative care alongside appropriate disease interventions such as high flow oxygen, such as a good assessment of the physical state. And I think also in Italy, the idea of giving a cutoff for intervention has gone away. So what we're coming back to is saying, this is an individual and a family, but we have principles that help us. And those principles reflect the comorbidities, the medical evidence for the benefit of any intervention that's available. They reflect understanding of how the pre-COVID functionality will affect recovery and any other underlying terminal illness. So those are the things we put together to make the best decision for the person in front of us, along with the patient and their family. Yeah. Psychosocial issues in the elderly, extremely important. Thank you, Dr. Sarika. And that's going to be specifically looked at on later on in the week. And you're very right, the PPE makes it difficult. Dr. Bijou will talk tomorrow about how we can use PPE, but still offer some way of connecting. And we'll leave that, I think, for tomorrow's discussion. You've given us a very good lead-in for tomorrow's discussion. But it also highlights how if we can have this conversation in advance, it's going to make it easier rather than waiting. So if you've got patients with comorbidities, start having these conversations, finding out their expectations long before they're desperately unwell and in an emergency room or in an ICU room. And I think you've made very good questions about what do we do when support is poor. I'm going to finish off this slide set and then we're almost finished for today, but thank you for all the interaction and the way in which you've brought up issues that we'll talk about later in the week. This is some quotes from doctors from Italy and New York talking about how they were handling these issues. You've talked about it being difficult. You've talked about the distancing. The Italian doctor saying, I'm feeling like I can't even stay human. I'm used to pushing mortality to the edge and I can't do it. But they're coming to the conclusion that actually what's important is our humanity. I wonder if you could just tell me, how do we maintain our humanity in the face of situations that are so challenging for us personally and so challenging for round about us? How do we stay human? So Nali, you're saying it's hard to stay human in critical care at the best of times. Yeah, thank you. How do we share our humanity? Because that is actually at the heart of good medicine, good clinical care. It's at the heart of good palliative care. It's actually at the heart of our global solidarity. We might be socially distancing or physically distancing, but we need to be together in the way in which we're caring for our patients and for each other. So ignoring our emotions is one way of coping, and that's what these doctors were saying, but it's only a short-term way of coping. We have to somehow come to a point where we are able to acknowledge those emotions. Let me just share something here as we're sharing this. This is a famous actor in India who was well known for his sensitivity and his openness to issues. And he himself was facing a terminal illness. And he talks about a whole life being an act of letting go, but it's tough to take a moment to say goodbye. Many of you are doing that with your patients, taking a moment, helping them take a moment to say goodbye, and those are very precious, important times. But just reflect for a moment, how do we show humanity? This is a Gaza medical student, a place which has lockdown for 11 years, talking about palliative care or holistic care, allowing him to demonstrate humanity until infinity. So as we just finish, I'm just going to let you have a moment to think of what that would mean in your setting. I'm loving the answers that are coming down here. And these are answers we're going to pick up. Dr. Dinesh, you might want to be able to summarize these for the sessions tomorrow, but I just love what you're saying. Communication, thank you, Vani, all the way from Mizoram. Human touch, lovely. Emotional intelligence, extremely important. And we don't measure that, do we? We're all about knowledge in clinical management and exams and not emotional intelligence. Wonderful. Expressing our humanity. Empathy. Wonderful.
There's certain issues related to communications in presence of PPs that will be strictly discussed during communication, I think. There they will specifically discuss that issue.
Lovely. So that is my encouragement to you as you go into tomorrow's sessions. Think about what it means to be fully human, and how we can do that without becoming too vulnerable ourselves. But also, in fact, I think it's the other way around. By being human in those scenarios, by sharing humanity, we actually are more of ourselves. We can actually form those kind of linkages of empathy and compassion that allow us to be better clinicians, but also allow our patients and families to be able to trust us and to feel that we're together with them facing these difficult issues. Thank you so much to everyone. Thank you to Dr. Dinesh. I think we've come towards the end of our session, and we're going to be picking up on many of those issues in the days ahead. Dr. Shilpa, what a lovely thing to say. Not allow people to become a bed number. Once people feel they are just a cog in the system, they are going to find it very difficult. But if we can make them feel valued and recognize our own values, that's going to make a huge difference. Humanity until infinity. I think for the last couple of minutes, I'm going to hand back to our course organizers, who will just give us a few housekeeping details as we finish this session. And my thanks to all for your input, and to Dr. Dinesh for sharing this session with me.
Thank you very much, Mhoira and Dr. Dinesh. And thank you to the participants. It seems like we're off to a really good start, Mhoira. And lots of ideas coming in, lots of thoughts being expressed. And that's really the essence of this kind of learning experience, where we learn from you as much as we're able to share. So please continue to use the chat box freely. Express your opinions, express your questions. I'd like to also, some of the other faculty are present here, Mhoira, so I'm just wondering if we should, just hear from some of them. Let me just check. I think we have Dr. Biju Raghavan who's here, and there's Dr. Rajam, there's Dr. Sunita. So any thoughts from any of you? May I please invite you to chip in if you have anything to add? And then we'll continue with the housekeeping rules and then wind up the session. Dr. Biju, there were several interesting questions about communication that came up. And like Mhoira has mentioned to all the participants, we will be covering communication as a separate module the day after tomorrow. Tomorrow is symptom control. And one thing that I would like all of you to please try and make some time for, because I know you're busy, is do access the resource toolkit. Because a lot of what is being covered over the next few days is there in the ebook, it's there in the webinars, and I think that will make your interactions also a lot crisper. And oh, there you go. Someone else also just used the word crisp, Rajam. Thank you. Just a little request. There are some participants who are signing in as a group from through one spoke or through one camera. If that is the case, I'm going to request that the attendance be shared with us, because on our screens you show up as one person, and for the certification it becomes very important that we know exactly who attended which sessions. So please do take that time to mention who exactly is present, if there is a group present where you are. Thank you very much. Raj Lakshmi, I just want to invite you to, there are a couple of points that I think you would like to highlight going forward in terms of just accessing the meeting at a particular time and so on. Raj Lakshmi is managing our virtual training department at Pallium India, and I'm sure most of you have been in touch with her already. But Raju, just to sort of reinforce some of the most important points, please.
Good afternoon to all. So thank you all for joining in. First of all, it is very good to see such a big crowd joining and attending our program. So it is an immense pleasure to have you all with us. It's always a mutual learning process, like ma'am said. So a couple of things I want you to note is that whenever you are logging in, make sure you give your name while logging in, because we can see a number of mobile devices logged in, like Nokia 7.1, Redmi and all. So the problem is that we will not be able to know your name and we can't mark your attendance, which will affect your certificate issuance process. So I request you all that whenever you log in, like the place where you're giving your meeting ID, there is a place above it where you can give your name. So if you're logging from Nokia 7.1, it is automatically given as Nokia 7.1. Just rename it to your name and then log in. And once you are logged in, make sure you are able to hear us. Like, just enable the audio option. You can see a microphone option at the left hand. Just click on it and press the call by device audio. You will be able to hear us as well as speak. We can hear you also. Whenever you are in the meeting, make sure you are muted when the faculty is having a presentation, and you can ask your doubts through chat option. If you have a doubt which should be cleared immediately, you will see a raise the option in the participants list. You can click on it and raise your hand, so that we will be knowing that you had something question to ask on.
We're also just reinforcing this because I understand that one or two participants had some trouble with the audio a little bit earlier. So just thank you, Rajalakshmi.
And one more thing, like if possible, try to log in by 2:50 p.m. So once your tech issues are solved, we can start our session right away from 3 p.m. onwards.
Okay.
Do we have some more time?
We have
over.
Yes, if Dr. Dinesh, would you like to say something?
No, you can invite some more questions, because you got some time.
I think our official time is over. But yeah.
No, we do have some time more.
We do have, I think.
So while the session, we had some people raising their hands. Was it accidentally, or if you have something more to clear on, you can just ask now.
So we can take up your queries now.
I think we kind of brought the session to an end, so I think it would be important.
That's all right.
Dr.
Sorry, Dr. Dinesh.
We still have around 50, around close to 60, and all 60 are still logged in. So no one has left effectively.
Also, okay, so let me just take this time to just quickly bring to your attention that with your confirmation email, there is a link to a Google form. It would be really helpful for you to fill that in, because that helps us with some of the information that we require to improve the quality of the program. So that is one. The second is, at the end of this session, as we close, there will be a feedback form that pops up, and that will also be very, very important for us. So bear in mind that being this kind of methodology, you will have maximum benefit from it, provided you've gone through the information in advance. So you'll also be prepped with the information that will be covered. Like Mhoira said, that we will be doing a lot of signposting. So I cannot reinforce enough that that would be a really important exercise for all participants. So happy to have your feedback and comments. And like Dr. Dinesh said, if there are any burning questions, happy to take it. We appear to have come to an end sooner than we thought just now, but that's all right. We have 5 more days of interaction.
So I think what we can do, Smriti, is just ask people to then do the preparation for tomorrow and the time that they have in their session, and we can just draw the session too.
All right.
You do is ask one question about signposting. Signposting means we give you ways in which you can find out more information. They're there on the slides, they're there in the ebook, so that you can find out information relevant to your own setting, whether that be the clinical setting you're in or the country you're in. So please do follow up on those things and use this little bit of time before tomorrow to think through some of the symptom control issues and follow up on those issues that we were discussing today, so that you're ready to come with questions tomorrow. Thank you so much.